Imagine a tangled mess of jump ropes, maybe, all twitching at once. That's kind of what a heart in fibrillation looks like.
Mm,
And just like that jumbled mess can't actually do anything useful, a fibrillating heart, well, it just can't pump blood effectively. It's
yeah,
just chaotic quivering.
yeah.
So today on the deep dive, we're tackling a listener's sources about defibrillation and cardioversion, these really critical procedures.
Absolutely vital stuff. And the material you shared, it gives this really grounded, practical take on it all.
Yeah.
Almost like getting the shop floor perspective from someone who uses this gear daily.
Right.
It might not be the official medical textbook, but that directness,
Yeah.
it's perfect for really getting a handle on the core ideas.
Totally agree. So our goal here is to get a clear picture. What's the real difference between the heart's normal steady rhythm and the absolute pandemonium of fibrillation?
Right.
And then how do these electrical shocks actually step in and restore order? We want to break it down, without getting lost in all the jargon.
Sounds like a plan.
So back to those wiggling jump ropes.
Yeah.
What exactly is fibrillation doing inside the heart?
Okay, so fibrillation is essentially a complete breakdown of the heart's electrical coordination.
Yeah.
The chambers just can't contract properly.
Okay.
Like one of your sources laid out, it can happen in the upper chambers, the atria. That's atrial fibrillation, or a fib. Or it can happen in the lower main pumping chambers, the ventricles. That's ventricular fibrillation, VFib.
And that bag of worms description people use.
Oh, yeah, that's spot on. It perfectly captures that rapid, totally uncoordinated twitching of the heart muscle fibers. It's like, think of a normal EKG, those regular spikes up and down. That's the heart's synchronized dance.
Right, the PQRS T waves.
Exactly. In fibrillation, that dance just dissolves into, well, chaos, a mess. That's what those really erratic, messy lines on the EKG are showing.
And that chaotic twitching, that means the heart isn't actually pumping blood, right? No real squeeze, no blood pressure.
Precisely. Yeah. When the chambers are just quivering, instead of giving a good coordinated contraction, they just can't push blood out effectively.
Hmm?
And that's why, clinically, especially with VFib, you see no cardiac output.
Yeah.
No pulse. Nothing.
Now, one of the things we looked at mentioned trying to connect those wiggly EKG lines to the actual physical movement of the heart chambers. Can you help us visualize that a bit more?
Sure. So picture the P wave on the EKG trace. That's like the electrical spark telling the atria, the top chambers, to squeeze.
Okay.
Then the big spike, the QRS complex, that represents the main electrical signal making the ventricles contract. That's the main pump.
Right.
And the T wave that follows, that's the ventricles resetting, basically recharging electrically, getting ready for the next beat. In a normal rhythm, this happens in a really predictable sequence: atria, then ventricles, squeeze, squeeze, reset.
Orderly. That seems to be the key word there. So how does this complete disarray of fibrillation compare to other heart rhythms that maybe aren't perfect but still have some kind of organization going on?
That's a really good distinction to make. Take atrial flutter, for instance. The atria might be beating super fast, maybe 300 times a minute, but there's still a pattern to it. It's organized, just too fast.
Okay.
And the ventricles, they don't necessarily respond to every single one of those fast atrial beats, so you might see a slower but still regular ventricular rhythm. It's fast, but it's not chaos.
And what about something like VTach, ventricular tachycardia?
Right, VT. That looks pretty scary on an EKG, those wide, fast beats coming from the ventricles. But again, it's technically an organized rhythm.
Still organized, huh?
Yeah. The problem with VT isn't the lack of organization. It's usually that it's so fast, the ventricles don't have time to fill up with blood between beats. And that can cause blood pressure to plummet dangerously low.
Okay. And then something we were wondering about reading the source. If someone's in ventricular fibrillation, VFib, are the atria, the upper chambers, also fibrillating? Is it just a complete electrical free-for-all everywhere?
That's actually a really insightful question. While VFib is the immediate, life-threatening emergency we have to fix now, what the atria are doing can actually vary. Sometimes in VFib, yes, the atria are fibrillating too, but not always. The critical thing, though, is that when you're faced with VFib, the absolute priority is stopping that ventricular chaos, because that's what pumps blood. What the atria are doing at that exact moment, it's kind of secondary compared to getting those main pumps working again.
Right. First things first, get the ventricles sorted. Okay, so we've got this picture of fibrillation, chaotic, not pumping. Now, how do we use electricity to, well, shock the heart back into line? One source called it treatment for nasty arrhythmias, which I thought summed it up pretty well.
Yeah, that works.
What's the core difference then between defibrillation and cardioversion?
Okay, the main difference really boils down to two things.
Hmm.
What kind of rhythm we're treating, and this is critical, the timing of the shock.
Timing.
Defibrillation. That's your go-to for the completely disorganized rhythms. We're talking ventricular fibrillation and also pulseless ventricular tachycardia. So VT, where there's no pulse.
Total chaos rhythm.
Exactly.
Yeah.
The goal here is to deliver a big jolt of electricity, a set amount, usually along the heart's normal conduction pathway, like lead 2 gives us a good view. The idea is to essentially hit a massive reset button, depolarize all the heart cells simultaneously.
Depolarize everything all at once. So the hope is that the heart's own natural pacemaker then just kicks back in.
That's precisely it. You wipe the electrical slate clean, momentarily silencing all the chaotic activity. Then you hope that the heart's natural leader, usually the SA node, picks up the baton and starts firing normally again.
Gotcha.
One of your sources had that pretty blunt quote, "Go defibrillate that disorganized rhythm, you doofus."
Yeah, I remember that.
It really hammers home the urgency, doesn't it? No messing around in those situations.
Definitely. Okay, so defibrillation is for when things have completely fallen apart electrically. What about cardioversion then?
Right, so cardioversion is for organized rhythms that are still causing trouble. Things like atrial fibrillation or that ventricular tachycardia we mentioned if the patient still has a pulse, and also supraventricular tachycardia, SVT.
Okay, organized, but still problematic.
Exactly. And the huge difference with cardioversion is the timing. We absolutely have to time the electrical shock very carefully.
Yeah.
We need to avoid delivering it during a specific vulnerable part of the heart's electrical cycle, the T wave.
Why the T wave?
Because hitting the heart with electricity right on the T wave, when the ventricles are repolarizing, can actually trigger ventricular fibrillation. It's called the R on T phenomena. Really dangerous.
Yikes. So you could actually make things worse.
Potentially, yeah. Which is why timing is everything in cardioversion.
So how does the machine know? How does it time it right?
Good question. The defibrillator, when it's in cardioversion mode, is designed to actually detect and track the QRS complexes on the EKG, the big spikes. When you press the sync button, synchronization, the machine puts little markers on each QRS it sees on the screen. Then it waits. It will only deliver the shock at a safe point in the cycle, usually on the R wave itself, specifically avoiding that dangerous T wave.
Ah, clever.
Yeah, and we even saw that example in your sources, didn't we? The patient with a fib who got an unsynchronized shock and went straight into VFib.
Yeah, that was a sobering reminder.
Definitely highlights why hitting that sync button is absolutely crucial for cardioversion.
Okay, so cardioversion, organized rhythms causing trouble, time shock is key. When would you typically use it? Give us some examples.
Sure. A really common one is atrial fibrillation with a rapid ventricular response. AFib with RVR, we often call it.
Right.
So the ventricles are beating way too fast because of those chaotic signals from the atria.
Yeah.
And because they're beating so fast, they don't fill properly with blood. And that can lead to low blood pressure, dizziness, feeling unwell.
Makes sense.
Now, if their blood pressure is okay, you might try medications first, things to slow the heart rate down. But if they're unstable or meds don't work, cardioversion is often needed to try and flip them back into a normal rhythm.
Okay, what else?
Ventricular tachycardia, VT, but only if the patient still has a pulse. VT with pulse. Even though it's organized, it can be unstable, and you worry it might degenerate into pulseless VT or VFib, so you'd cardiovert.
Got it.
And also supraventricular tachycardias, SVTs. These are very fast rhythms starting above the ventricles. If they're causing serious symptoms or making the patient unstable, cardioversion can be the way to go.
And I remember one source made that interesting point that atrial fibrillation is kind of just about organized enough. What did they mean by that?
Yeah, that's a pretty good way to put it, actually. I mean, even though the atria themselves are quivering chaotically, some of those electrical signals still manage to get through the AV node down to the ventricles, often erratically, which is why the pulse is irregular in a fib. But there is still some organized ventricular activity happening, unlike in VFib, where it's just complete electrical anarchy in the ventricles. So, yeah, just about organized enough kind of fits.
All right, so we understand the why and the when for these shocks. Now let's talk about the actual machine, the defibrillator itself. What are the key parts we need to know?
Okay, yeah. The defibrillator, despite its life-saving job, is actually fairly straightforward in its components.
Yeah.
First off, you've got the monitor, the screen.
Right, got to see what's happening.
Exactly. It shows the patient's heart rhythm. We can see that either through standard EKG leads stuck on the chest, or using the paddles themselves for quick look mode, or increasingly common now, through adhesive pads.
Pads, okay.
But yeah, it's absolutely vital that the machine is accurately seeing the patient's rhythm. Getting a clear lead 2 view usually gives us the best overall electrical picture of the heart.
Makes sense. Know the problem before you fix it. What's next on the machine?
Next up is the capacitor. You can think this is the energy storage tank. The defibrillator has a battery. Obviously, that's why they can be kind of heavy. And that battery charges up this capacitor. When we dial in an energy level, say 150 joules, the capacitor stores exactly that amount of electrical energy ready to be delivered.
Ah, and that's the whirring sound you hear.
That's usually it. Most machines make that rising, whining, or whirring sound as the capacitor charges, and it often stops or changes tone when it's fully charged.
Gotcha. And then you've got the buttons and dials. Hopefully pretty simple, especially under pressure.
That's definitely the design goal. Yeah. A lot of machines follow a simple 1, 2, 3 process. Button 1, or maybe a dial, is to turn it on and select the energy level in joules.
Okay.
Button 2 starts the charging process, filling up that capacitor.
Right.
And button 3 is the discharge. Often it's actually 2 identical buttons, usually one on each paddle, or a single button on the machine if using pads. You typically have to press both simultaneously on paddles to prevent accidental discharge.
Makes sense for safety.
Absolutely. But yeah, getting hands-on familiar with the specific machine you might encounter is really key. They all do the same job, but the layout can vary a bit.
Okay, so power and set energy, charge, discharge. What about getting the electricity to the patient? Paddles versus pads. You mentioned pads are becoming more common.
Yeah, historically paddles were the standard, metal things you hold. And they're still important, especially in those super urgent crash bang emergencies where you need to act instantly, grab the paddles, gel them up, and go.
Right.
But adhesive defibrillation pads are definitely being used more and more, especially for planned cardioversions. They look similar to external pacing pads, big sticky patches you put on the chest.
And what are the advantages of pads?
They tend to have a larger surface area, which can mean better contact with the skin. That can lead to more effective energy delivery and maybe less risk of skin burns compared to paddles if not used perfectly. Plus, they stick on, freeing up your hands. In a real code situation, if paddles are right there, you use them. Don't waste time. You can always switch to pads later if needed. And sometimes placing pads front and back, anteroposteriorly, might give a better current pathway through the heart, especially if you might also need to pace the patient later.
Interesting. Okay, we've got the hardware down. Now the science bit. How does this electrical shock actually work? How does it get the heart beating normally again? What's the magic?
Hey, well, not quite magic, but it's pretty amazing physiology. The key principle is depolarization.
Depolarization. Okay.
Normally, the heart's electrical system relies on this really precise, timed flow of ions, charged particles moving in and out of the heart cells. This movement creates a temporary reversal of the electrical charge across the cell membrane, that's depolarization. Then the cells repolarize, getting back to their resting state.
And that creates the EKG waves.
Exactly. That electrical activity generates the P wave, the QRS, the T wave, and it travels in a very specific sequence through the heart's conduction system, causing those coordinated muscle contractions that pump the blood.
Okay, so what goes wrong in these bad rhythms?
In lethal arrhythmias, like VTach or VFib, basically a faster abnormal electrical focus takes over. It overrides the heart's natural pacemaker and disrupts that orderly sequence.
Like a rogue signal hijacking the system.
That's a great way to put it.
Yeah.
In VFib, it's even worse. You've got multiple chaotic electrical signals firing off all over the ventricles simultaneously. That leads to that useless bag of worms twitching.
Right. The chaos.
So the electrical jolt from the defibrillator. The goal is to deliver enough energy to depolarize all the heart muscle cells at the exact same moment.
Overwhelm everything.
Precisely.
Yeah.
This sudden massive depolarization interrupts all that chaotic electrical noise. It essentially hits that reset button we keep talking about. And the hope, the physiological hope, is that this brief electrical silence gives the heart's own natural pacemaker, the SA node, a chance to regain control and start firing off a normal, regular rhythm again.
So overwhelm the chaos with one big electrical command.
Got it. Now, we keep mentioning joules. We had the fun definition earlier, but practically speaking, what is a joule in this context?
Yeah, simply put, it's a unit of energy. That hunk of electricity description wasn't far off. When we select, say, 200 joules on the machine, we're choosing the amount of electrical energy that capacitor is going to store and deliver in the shock.
And how do they figure out the right amounts?
Well, that comes from a lot of research, medical engineering, and unfortunately quite a bit of animal research historically, to determine the energy levels that are most likely to be effective for converting different arrhythmias without causing excessive damage.
Okay.
While the physics gets complex, just understanding it as the dose of electricity is enough for most people. And that comparison we saw, that 360 joules is roughly the energy to crank over a big diesel engine.
It really gives you a sense of the power involved, doesn't it? Although it's worth noting that even though 360 joules could start a truck with modern biphasic shocks, a much smaller nudge of electricity, because it goes back and forth, is often enough. It can be more effective at lower doses, which is better for the heart tissue.
That is a memorable comparison. And you just mentioned biphasic. We heard about monophasic versus biphasic defibrillation. What's the difference there and why does it matter?
Right, so monophasic is the older technology. The electrical current travels in only one direction between the paddles or pads, from negative to positive.
Okay, one-way street.
Yep. Biphasic is the newer and now pretty standard technology. It delivers a current that flows in one direction initially, but then it quickly reverses and flows in the opposite direction for the second part of the shock.
Back and forth. And why is that better?
The big advantage is that biphasic shocks are generally effective at lower overall energy levels compared to monophasic.
Ah, less power needed.
Exactly. And that's better for the patient. Less energy can mean less potential stress or damage to the heart muscle itself. Plus, it means the batteries in the defibrillators can last longer, or you can make smaller implanted defibrillators, ICDs. So, more efficient, maybe a bit gentler.
Makes sense. Okay, now another term from the source. Transthoracic impedance. Sounds pretty technical.
It does, but the concept is fairly simple. Transthoracic impedance is basically just the electrical resistance that the patient's chest offers to the flow of electricity during the shock.
Resistance, like in electronics.
Kind of, yeah. Think of it like trying to push water through a hose. A wider hose has less resistance than a narrow one. Similarly, the chest resists the flow of electrical current.
What affects that resistance?
Things like the patient's body size, how much air is in their lungs at that moment, bone structure, and critically, how good the contact is between the skin and the paddles or pads. Poor contact means higher resistance.
And why does it matter?
Because higher impedance, higher resistance, means you might need more energy to get enough current through the chest wall and actually to the heart muscle to do the job of depolarization. What's really cool is that many modern AEDs, the automated ones you see in public places, they're smart. They can actually measure the patient's transthoracic impedance really quickly and automatically adjust the energy level of the shock they deliver to compensate.
Wow, that's clever.
It really is. They try to deliver the most effective shock possible based on that individual patient's resistance, like sensing how thick the hose is and adjusting the water pressure accordingly.
That's impressive tech for a public access device.
Yeah.
Okay, let's get practical now. Let's walk through the steps. Starting with cardioversion for those organized but problematic rhythms. How does that usually go down?
Right. Cardioversion, as one source nicely put it, is often for patients who are not quite in a code yet.
Meaning you have a bit more time.
Usually, yes. A bit more time to prepare, especially if it's an elective, planned procedure. So essential setup includes having enough people there, doctor, nurses, maybe anesthesia personnel if sedation is needed.
Okay.
You absolutely need good IV access. Got to have a line in just in case you need to give medications quickly or if things go south.
Right. Backup plan.
And the patient must be unconscious or sedated. You would never, ever cardiovert someone who's awake and alert. It's painful and frightening.
Definitely not.
And finally, make sure they're getting oxygen. The arrhythmia itself might be compromising their oxygen levels. Or maybe hypoxia is even contributing to the arrhythmia. So good oxygenation is key.
Okay, patient prepped, IV in, oxygen on, sedated. What's step one of the actual procedure?
Step one is selecting the right energy level, the dose. For cardioversion, we generally start lower than for defibrillation.
Lower dose, okay.
For example, for that AFib with RVR we talked about, you might start around 50 joules with an older monophasic machine, or maybe even a bit lower, like 50 or sometimes 100 joules biphasic, depending on the protocol. For VT with a pulse, maybe a bit higher, perhaps 100 joules biphasic.
So it depends on the rhythm.
Yes, absolutely. The key is knowing the recommended starting doses for different rhythms and being familiar with how to select and adjust the energy on your particular machine.
Got it. Start lower for cardioversion. What about seeing the rhythm clearly?
Crucial for cardioversion because remember, we need to synchronize. So you need to have the patient hooked up to the EKG monitor function of the defibrillator, usually with 3 sticky EKG electrodes placed for a standard lead 2 view.
Why lead to specifically?
Lead 2 typically gives a nice, clear, upright QRS complex, which makes it easier for the machine to detect it accurately for synchronization. But really, any lead that shows a clear, tall QRS without much interference will work. You just need the machine to reliably see that R wave.
Okay, clear view established. Then comes that all-important sync button.
Exactly. This is the defining step for cardioversion. You press the sync button. This tells the machine, okay, don't just fire when I hit the button. Look for the QRS complex and deliver the shock on the R wave safely away from the T wave.
And you can see it's working.
Yep. When sync mode is active, you'll usually see a little marker, maybe a dot or an arrow or a triangle, appear on the monitor screen, flashing above each QRS complex the machine detects. That's your visual confirmation that it's synchronized.
Okay, so energy selected, rhythm visible, sync button pressed. Then what?
Then comes step 2, which is charging the machine. You hit the charge button, listen for those charging tones, and wait for it to signal it's ready at the selected energy level.
And finally, step 3, delivering the shock. What are the absolute must-dos here?
Okay, step 3, discharge. First, conduction gel. If you're using paddles, you must apply conductive gel liberally to the paddle surfaces. If using pads, make sure they are firmly adhered to the skin with good contact, no gaps.
Why is the gel or good contact so important?
It ensures the electricity conducts efficiently into the patient, rather than arc-sync across the skin surface, which is ineffective and can cause nasty burns.
Got it. Gel or good pad contact. Then what?
Then, the absolute non-negotiable safety step. Clear the bed. You shout it loudly and clearly. I'm clear, you're clear, everybody clear. Scan to make visually sure nobody, including yourself, is touching the patient or the bed frame or anything connected to the patient. Get verbal confirmation back if possible.
Safety first. Always.
Always. Then, if using paddles, position them firmly on the chest. Standard placement is the lead 2 position.
Yeah.
One paddle, often marked sternum or negative, on the upper right chest, just below the collarbone. The other paddle, apex or positive, goes on the lower left side of the chest below the nipple, kind of in the armpit line.
And you mentioned pressure.
Yes, significant pressure, like 25 pounds of pressure, as one source mentioned. Push down firmly to ensure really good contact through the gel. Reduces impedance.
Okay. Paddles placed, pressure applied, everyone's clear. Then shock.
Then you press both discharge buttons on the paddle simultaneously, or the single discharge button on the machine, if using pads, and hold them down. Because it's synchronized, remember, the machine might wait a fraction of a second to deliver the shock on the next R wave.
Ah, right. Don't let go too soon.
Exactly. Hold them until the shock is delivered. Then immediately look at the patient and look at the monitor. See if the rhythm changed. Did it work? What's the new rhythm?
Okay. And if using pads for cardioversion?
Placement is usually similar. One pad, upper right chest, one lower left axilla. Or, as we mentioned, sometimes an anterior, posterior, front, back placement is used, which some feel gives better current flow through the heart mass and can also be useful if pacing is needed. Pads are often preferred for elective cardioversions just because the contact is generally more reliable and consistent.
Got it. That's the careful, timed, synchronized approach for cardioversion. Now shift gears. What about defibrillation, VFib, or pulseless VTach? This is the real emergency, right?
Absolutely. This is a code situation. Time is critical. As the source said, shock them first is often the mantra, meaning it's a top priority right alongside good CPR.
Okay, what are the first steps?
First, confirm unresponsiveness and absence of pulse. Is this actually a pulseless arrest situation? And always be aware, is there a DNR, a do not resuscitate order?
Crucial check. Then energy levels.
For defibrillation, you're generally starting higher. With older monophasic machines, maybe 200 joules, sometimes higher, like 300 or 360. With modern biphasic machines, the recommendation is often around 150 to 200 joules for the first shock, though you follow specific device or local protocols. Be ready to escalate the energy for subsequent shocks if the first one doesn't work.
And the sync button.
Do not use the sync button. This is the key difference on the machine side. In VFib, or pulseless VT, there's no organized QRS to sync to, and you need to deliver that shock immediately. Don't waste precious seconds waiting for synchronization. That won't happen.
No sync for defib. Got it. What else?
Apply gel or pads quickly and correctly. Clear the patient just as carefully. Everybody clear. Charge the machine. Deliver the shock. Then immediately resume CPR. It's often recommended to keep the paddles or pads on the chest between shocks if possible, so you can quickly glance at the monitor, set to paddle view or pads view, during the brief pause in CPR for rhythm checks.
So it's a faster, more immediate process, maybe multiple shocks needed.
Often, yes. If the first shock doesn't convert the rhythm, protocols usually call for immediate resumption of CPR, followed by another rhythm check and potentially another shock, often at the same or a higher energy level. Sometimes it's a sequence, shock, CPR, maybe medications, shock again. Very dynamic.
Speed and energy are key. Now, the source material had a really useful section on things to watch out for, common mistakes or pitfalls. What were the big takeaways there?
Yeah, really important safety points. Number one, again, never ever shock an awake patient. Cardioversion requires sedation. Defibrillation is for unresponsive patients.
Okay, what else?
Always synchronize for cardioversion. For those organized rhythms, hitting that sync button is non-negotiable to avoid inducing VFib.
Right. Sync for cardioversion, no sync for defibrillation.
Exactly. Third, always use conduction gel with paddles or ensure pads have full contact. Prevents burns, ensures effective shock.
Got it.
Fourth, always clear the bed. Loudly, clearly, visually confirm. Protect yourself, protect your team. It sounds basic, but it's easy to miss in a crisis.
Absolutely critical.
Also, try to maintain a calm, orderly process, even in chaos. Clear communication is vital. Who's doing what? Who's in charge? And finally, always recognize that these situations can escalate. If you're cardioverting someone, be prepared for them to potentially arrest. Have backup. Have your arrest cart nearby. Know your algorithms.
Excellent points. Safety, clarity, preparation. And finally, what about after the shock? What care is needed once someone's been cardioverted or defibrillated?
Yeah, the care doesn't stop with the shock. It's just as important. First, continuous monitoring. Keep them on the monitor. Watch that heart rhythm closely. Is it stable? Does it revert back?
Okay.
Maintain good oxygenation. Keep their O2 sats up, usually above 94, 98%. But be mindful if they have underlying lung disease like COPD, where you might aim slightly lower.
Check labs.
Definitely. Check electrolytes, especially potassium and magnesium, as imbalances can contribute to arrhythmias. Assess their acid-base status. Are they acidotic?
Makes sense.
Get a formal 12-lead ECG afterwards. This gives a much more detailed picture of the heart's electrical activity than just the monitor strip. Look for underlying problems, signs of heart attack, or injury from the shock itself.
What about the patient themselves?
Ask them about chest pain. Was it there before? Is it better or worse now? Consider checking cardiac enzymes like troponin, especially if you suspect underlying heart muscle injury or if it was defibrillation for cardiac arrest. And of course, check the skin under where the paddles or pads were. Look for any redness or burns and treat them appropriately.
So a lot of follow-up assessment. It's definitely not just about the jolt itself.
Not at all. It's the whole package, the procedure, and the careful monitoring and care afterwards.
Well, this has been a really thorough deep dive into defibrillation and cardioversion. Let's try and quickly recap the absolute key takeaways.
Okay, big picture. Defibrillation is for the disorganized, life-threatening chaos like VFib. Goal is a massive electrical reset, no synchronization needed.
Right.
Cardioversion is for organized but problematic rhythms like AFib, RVR, or VT with a pulse. The absolute key here is synchronizing the shock to the R wave to avoid the T wave.
Got it. Disorganized, defib, no sync. Organized, cardiovert sync.
That's the core difference in action. And remember the basics of the machine. Monitor to see the rhythm, capacitor to store the energy, simple controls, and paddles or pads to deliver it. Depolarization is the mechanism wiping the slate clean. And safety first, always. Sedation for cardioversion, gain good contact, clear the patient.
Excellent summary. You know, understanding these procedures, even conceptually, really gives you a window into some powerful emergency medicine, how we can use electricity, basically, to pull someone back from the brink.
It's pretty incredible stuff when you think about it.
And on that note, here's something maybe for you, the listener, to ponder. With all the advances we've talked about, biphasic energy being more efficient, those smart ADs adjusting for impedance, what does the future hold? Are we heading towards even more personalized, even more effective ways to treat cardiac arrest, maybe even faster, outside the hospital?
That's a great question. The field is definitely always evolving. Think about wearable defibrillators, faster public access, maybe AI assisting with rhythm interpretation.
Exactly. It's fascinating to think about where this technology might go next.
It truly is. Constant innovation, trying to improve outcomes for such a critical event.
Well, we'd love to hear from you. Did you have any aha moments listening to this, or are there still some questions buzzing around? Let us know. Your curiosity often sparks our next deep dive. Thanks so much for joining us today.